Hi all, welcome to Raaonline. Today we are going to deal with one interesting topic that will test the anesthesiologist with anatomy, physiology and pharmacological intervention. Not only that, your technical skills also will be put into questions. Cannulating a child with pulmonary hypertensive crisis or a cyanotic spell is not going to be easy. That is congenital heart disease for you. In the next 45 minutes, I will be talking about a brief introduction of congenital heart disease, then deal with them individually. What are the preoperative imaging modality which will you do, therapeutic concerns in the intraoperative period, and before winding up, I will give a small brief account about infective endocarditis and how you balance the circulation by altering your pulmonary vascular resistance and systemic vascular resistance. Before 1980s, you can see the mortality from congenital heart disease is around 28%. Since the mortality was very high, the children with congenital heart disease progressing to adulthood is very minimal. But after 1990s and early 2000, lot of advancement happened in cardiac surgery and cardiac anesthesia, and you can see the mortality is reduced around 3%. Because of this, the child with congenital heart disease progressing into adulthood drastically increase. The clinical implication of this diagram is you are going to face more and more patients with congenital heart disease coming for non-cardiac surgery. Congenital heart disease has a special liking for number 3. They come for 3 types of surgery. One is cardiac surgery. Either they come for primary repair or come for a redo surgery. Or they might come for non-cardiac surgery or go into a cath lab for a catheter-based intervention. And they can be classified into 3 types based on the lesions. It can be a left to right shunt or a right to left shunt or an obstructive lesion. With regarding to pulmonary blood flow, another 3 types. It can be high, normal or low pulmonary blood flow. And another way to look at congenital heart disease is that the ventricle and gate vessels. You can look at the inflow of the ventricle, outflow of the ventricle or the great vessels relationship. It can be classified into 3 types of categories. The patient with complete correction and who is normal. The patient with partial or palliative surgery. Here, the patient might be off normal or off abnormal or totally non-operated, where you have to look at the pathophysiology of individual congenital heart disease. There are 3 types of categories. The highest categories are severe pulmonary artery hypertension, uncorrected cyanotic congenital heart disease, complex congenital heart disease with residual like heart failure, valve disease or the need for anticoagulation, prior Fondant procedure for single ventricle physiology, malignant arrhythmias. Coming to high risk categories, here the pulmonary artery hypertension is moderate, partially corrected cyanotic disease like a BT shunt done for a cyanotic congenital heart disease, severe systemic ventricular dysfunction where your ejection fraction is going to be less than 35%, severe left heart obstructive lesion. These are all high risk category. Coming to moderate risk, where you place the prosthetic valve or conduit, a intracardiac shunt, moderate left heart obstruction and moderate systemic ventricular dysfunction. There is highest, high and moderate risk. There is no low risk category. How are you going to assess the perioperative risk in patient with congenital heart disease coming for non-cardiac surgery? This was a risk scoring system which was done by Harvard, which has 9 variables with each variable having 0, 1 and 2 points. The first variable is the complexity of the diagnosis. A simple ASD has 0 point. A moderate lesion will have 1 point and severe like a complex tetralogy of Fallot or transposition of gate arteries will have 2 points. Coming to the intervention, when the patient is undergone surgery and fully corrected and there is no residual, it is 0. Corrected with residual, it is 1 point. only palliative surgery done, it is 2 point. And coming to the ventricular obstruction, when there is no ventricular obstruction, it is 0. When there is obstruction and when the gradient is less than 49 millimeter of mercury, it is 1 point. When the gradient is greater than 50 millimeter of mercury, it is 2 points. Coming to the number of ventricle as well as the position. There are 2 ventricle and left ventricle is a systemic ventricle, which is the usual circulation. It is 0 point. When there is only 1 ventricle, but the left ventricle is a systemic ventricle, that is 1 point. When there is 1 ventricle, but the right ventricle is a systemic ventricle, you have 2 point. Coming to the ventricular dysfunction, if it is mild, it is 0. If it is moderate, it is 1 point. If it is severe dysfunction, it is 2 points. Coming to pulmonary vascular resistance, if it is normal, 0 point. Between 2 and 4, it is 1 point, and greater than 4, it is 2 points. Coming to the saturation of the patient, if it is greater than 90%, it is 0. Between 75 to 90%, it is 1 point, and if it is less than 75%, it is 2 points. Coming to the hematocrit, between 30 to 45%, it is 0. If the hematocrit is between 25 to 30 or between 45 to 65%, it is 1 point. That means either the child is anemic or slightly polycythemic, it is 1 point. If it is overtly polycythemic, that is greater than 65%, it is going to be 2 points. Coming to arrhythmias, there is no arrhythmias, it is 0 point. Atrial level arrhythmias, it is 1 point. Ventricular level arrhythmias, it is 2 points. Coming to number of medication which patient is receiving, if it is 1, the point is 0. If the number of medication is 2, the points is 1. And if the medication is going to be greater than 3, it is going to be 2 points. How will you assess the risk with this scoring system? If it is between 0 to 6 point, the risk is minimal. If it is between 6 to 13 point, the risk is moderate. If it is between 14 to 20 point, the patient is going to fall in the high risk category. This is how you risk satisfy the patient with congenital disease coming for non-cardiac surgery. Now coming into individual lesions. The most common congenital heart disease, left to right shunt, that is atrial septal defect. Here you have 4 type of ASD. The most common type is the ostium secundum ASD, which is a defect in the middle of the atrial septum. The next type is going to be the ostium primum ASD. Here you can see the defect in the lower part of the atrial septum. The third one is called the sinus venosus ASD, where your SVC or the IVC blood goes via ASD into the left atrium rather going into the right atrium. Here you can see the SVC blood going via ASD into the left atrium. And the fourth type is called the coronary sinus ASD, where the coronary sinus blood goes into the LA. These are the 4 types of ASD.